Good morning. Pleasure to be here, and thanks for the organizers for having us, giving an update on SELECT-2 that we just started. Here are my disclosures. The most relevant is that I am the global PI for SELECT-2 that is funded by Stryker Neurovascular. So the study addresses two major questions in the field. The first one, imaging selection prior to thrombectomy. And we know that the early window trials mostly use CT for imaging selection and used an aspects cutoff of 6 or more. Dawn and Diffuse 3 used perfusion images with it. It is imaging mismatch or clinical imaging mismatch, and that's reflected in the American Heart Association guidelines and most of the practices that in the early window, initially they said perfusion is not recommended. Later on, they rescinded it. In the late window, perfusion is recommended based on Dawn and Diffuse 3 results. So that's a major question. So this is a select paper that will be published by the ISC Time. When you do both CT and CT perfusion, you have 4 possibilities, and that's what most of the practices do. Both of them looking good, and that's the majority of the patients that were enrolled in the trials prior to large cohort trials. The most likelihood of good outcome, but there are cases where CT and CT perfusion disagree, and you come to a bind. What do I do? Do I treat? Do I not treat? If you're a CT center, you don't treat by perfusion and vice versa. And there is the cases where both look poor and the large core, so to speak. So if we focus on those, we looked further into our data about the discordance, and you can see to your right, even in the cases where you have perfect aspects, you have core volume more than 50 and more than 100. And you see even in the cases where you have low aspects, you might have small core. So is there a heterogeneity in treatment effect in these 3 areas? We looked further into comparing this to medical management. Both cases, and it seems one imaging modality being good is enough to treat the patients. When successful reperfusion was associated with an improved outcome. So this is the first question. Is there a heterogeneity of treatment effect based on the initial imaging findings? When you think about it, and this is a graph of treatment decision by having concordant, both blue, somebody having a good CT and a good CTB, they have a very likelihood of being treated. But as time window increases, and some of our patients were prior to Dawn and Diffuse 3 results, the likelihood decreased, but it's maintained mostly. While in red, the ones who have one imaging profile good, the other is not being good, the likelihood of being treated less, and it decreases with time. So those are a lot of these patients going to be included in SELECT-2. How about the likelihood of good outcome? This is the around 50% to 60% good outcome likelihood that you see in the results of the Hermes or Dawn and Diffuse 3. But if you have one imaging modality not being good, your likelihood decrease. The medical management is not included here, and the question is, would we do better than medical management? Now, the second and probably the major question of SELECT-2 is the large core, and we know by now that all of the trials mostly used aspects more than 6, core volume less than 50 or 70, perfect imaging profiles for eligibility, and excluded those patients with lower aspects or large core, and those are the target that we are including in SELECT-2. And the other question, when we stay within imaging, this is data that we presented at the ISC from SELECT and TREVO, looking at the heterogeneity by aspects and core volume. This is a patient with an aspects of 4 and a core volume of 92 cc's. We hypothesize that this is different than an aspects of 4 and a core volume of 174 cc. So this data was published recently, looking at the large core was the basis for SELECT-2 power analysis, and there was a shift towards better outcomes overall in thrombectomy as compared to medical management. So the questions that we are asking is, can thrombectomy be safe and efficacious in patients with poor profiles on CT or perfusion, i.e. the large core, and this is what we are testing. Can CT and CT perfusion perform similarly, or there is a heterogeneity in treatment effect? And can we use CT beyond 6 hours? And we try to look into this in a randomized fashion as we're doing. So this is the design of SELECT-2. The objective, as I said, looking at the large core safety and efficacy of thrombectomy in this patient population with an aspect of 3 to 5 or a volume on perfusion more than 50, whether ADC or RCBF. All of the patients will get CT, and CT perfusion, and looking at the heterogeneity of the treatment effect in the discordant imaging profile. This is a prospective, randomized, multi-center, open-label phase 3 clinical trial of the blinded outcome assessment. Has 30 sites in the United States, Canada, Europe, and Australia. Enrollment up to 560 patients. We are looking at a shift analysis. It's not too bad to have an MRS of 3 if you have a large core stroke. We are including the regular inclusion criteria, age 18 to 85, ICNM1 occlusion, NIH 6 or more, no baseline disability, with an adaptive covariate design to look at the 12 hours cutoff and the different cutoff on the volume. So we want to answer the question, is it effective and safe in large core? But we want to see if there is a ceiling and a cutoff, and we want to balance things between right and left and occlusion site, et cetera, et cetera. We have 2 interim analyses at 200 and 380. This is your algorithm. You meet the inclusion criteria, you get randomized to thrombectomy versus medical management. We're including aspect of 0 to 2. We're tackling the imaging question by looking at is there a superiority or the opposite, non-inferiority of selection based on CT versus perfusion. If they disagree, of 15% difference, and that's based on select finding. Is there a heterogeneity, meaning the treatment effect thrombectomy versus medical management? And we're going to have randomized patient here, thrombectomy versus medical management, unlike retrospective analyses and things like that. And if you think about it in the late window, if you have a good CT and a poor CTP and thrombectomy is better than medical management, then CTB findings did not affect your decision and outcome. These are our sites, as I mentioned, United States, Canada. We have sites in Spain, Portugal, and Norway, and Australia. So we just started. We started enrollment last month. We have a few patients in. We're going to have our first interim analysis, and hopefully when we come back to you in a year or two, we will have good results and successful to increase the indications for thrombectomy. Thank you.